Afternoon, Unite for Her community. Happy Friday. Erin Pellegrin here for your monthly Ask the Experts this lovely Friday afternoon. So hopefully some of you will tune in just a few moments. I'll give everyone a little bit of time to pop on and start watching. We have a really exciting topic. We've touched a little bit on this, actually quite extensively on our topic, and we've chatted with our expert before for a past speaker series for the month of February. So if you haven't had a chance to check that out, be sure that you do. All about genetics. It's in our Her library, so be sure you check that out. But we were so engaged and so enthralled with one of our speakers and one of our experts from Penn, we decided to bring her on back to chat a little bit more about genetics. So as always, our Ask the Experts series, just a couple of reminders, is our monthly session that we get to bring in some of the best in our industry and those that are thoughtful to our community to pick their brains, ask those common questions, but also engage in our community. So remember, as we stream live over Facebook, you're welcome to answer your own questions or add your own comments live as we're speaking with our expert. We do these every month. We have two special Ask the Experts for April, which I will touch on a little later. But I want to make sure that I give special thanks to our presenting sponsor, Merck, and our supporting sponsor, Exact Sciences. They have been such wonderful supporters of our entire digital education series. And without them, we wouldn't be able to bring on guests like we have today and discuss really important topics like genetics that we will be covering today. So let's get started because I know there's a lot of information to cover. So as a proper introduction for those that, again, didn't attend our speaker series, we are bringing back board certified genetic counselor Danielle McKenna. She is from the University of Pennsylvania's Abramson Cancer Center, and Danielle provides cancer risk assessment and genetic counseling services to individuals and families affected by cancer. So without further ado, I hope everyone watching welcomes our esteemed guest, Danielle, onto our Ask the Experts. How are you? Good afternoon.
I'm well. How are you?
I'm good. Thank you so much for coming back and being with us. I know we had so much good communication and engagement in our speaker series, and both Sue and I were just like, we have to have her back. There's so much more to cover. So I'm glad you're with us today.
Thanks for having me.
Of course, of course. So why don't we dive right into these questions? Because I know there's a lot of information to cover. I want to make sure we get as much reviewed as we can. So to start off, Danielle, for those that are wondering, who should get genetic testing?
Yeah. So the list continues to grow. There's more and more people who are qualifying for genetic testing. So this is not by any means the conclusive list, but these are kind of the simplest criteria or the low-lying fruit. And so that's anyone with breast cancer diagnosed under the age of 50, anybody with triple negative breast cancer, which means that their breast cancer was negative for estrogen, progesterone, and HER2. Anybody with male breast cancer should see genetics. That's a pretty rare type of cancer that warrants genetic follow-up. And then also, if someone has Eastern European or Ashkenazi Jewish background and they have breast cancer, that would meet criteria for genetic testing as well. And then outside of the kind of realm of breast cancer, anybody with pancreatic cancer, anybody with ovarian cancer, anybody with metastatic prostate cancer, those are all other people who very easily meet genetic testing criteria. And they might have actual treatment benefits to being genetically tested. So those are kind of the low lying fruit of who should get genetic testing. But by no means is that an all-inclusive list.
Okay. And would someone, if they wanted to get genetic testing or wanted to inquire about it, is it something they should approach their physician with, or should they seek out a genetic counselor on their own? How would one kind of follow up with that?
Yeah, so you could ask your physician, you could ask your oncologist, or you can actually Google find a genetic counselor, which should bring up our national database, so National Society of Genetic Counselors. You put in your zip code, you put in the specialty that you're looking for, which would be cancer in this situation, and it'll tell you where your nearest genetics providers are.
Oh, good to know. Okay, so we have a couple different resources. Okay. In terms of accuracy for genetic counseling, how accurate is it? I feel like we've probably come a long way over the last several years and decades. So where are we right now?
Yeah, so most clinical genetic testing laboratories are about 99.9% accurate with their results. So it's really accurate testing. What can happen though, and I think this kind of ties into another question, which is, should I repeat genetic testing if I've had it before? So what can happen is technology can improve. And so it's not that your DNA changed, it's just that our ability to detect mutations might have improved over the last 10 years or so. Mm-hmm. So an easy cutoff for people who've had negative genetic testing in the past and are wondering if they should come back for more testing is if you had it prior to 2013, I would definitely come back because we've had some significant technological improvements since 2013. So if it was before 2013, I would come back. If it's after 2013, it's a little bit harder to know if they've had the most up-to-date testing or not. It kind of depended on who they saw and what their preferences were and what their insurance covered. So it's a little harder to predict after that. But before 2013 is a pretty easy, come back and get data testing.
Okay. Do they have to go back to where they received genetic testing prior, or, maybe if there was a new geographical location, or, the facility that they went to is no longer in existence? Is that okay?
Yeah, they can go somewhere new. Sometimes it's helpful to go where if it's easy to go where you went last time, they already have your family history on file. They have your previous results on file. So that makes it a little bit easier. But if it's not easy, it's totally fine to go somewhere new for that.
Okay, perfect. And you mentioned insurance coverage. I think that's a really good question because people want to know, is it covered by insurance? If they don't fall into one of the categories that you mentioned early on, is that an indicator of coverage? What do you know about that?
Yeah, so the criteria I mentioned early on does come from national guidelines. So anybody that I listed before should meet national guidelines for genetic testing criteria, which pretty much any insurance company is going to cover. Okay. For people who don't quite have that history, or maybe have, a family history of those things, but not a personal history of those things, it really depends on your insurance. But what I can tell you is that if you see a genetic counselor, they know the billing really, really well inside and out. And most of the labs that we use offer pre-verification for all of our patients. Okay. And so the policy for a lot of labs today in 2022 is that they run a pre-verification and they have to tell the patient if it's going to be more than $100 out of pocket. Wow. So typically you're not being billed more than that unless you agree to it. Right. And a lot of labs are offering patient pay prices. So if your insurance totally denies it, the lab can offer you the patient pay price of $250 as a pretty common cost amongst labs. So it's a lot more affordable than it's been in years past when it was like $5,000, and that's obviously very prohibitive. Yeah. So more and more people are getting it even if their insurance denies it because it's more affordable. Right. Do you think it's something that everyone with a cancer diagnosis should at least consider or have a discussion with their medical team if it's appropriate? That's a great question. I think we'll be there in the next 5 to 10 years. I think probably every cancer patient will get genetic testing. Mm-hmm. We're not quite there yet because not everybody's going to meet criteria. Not everybody has a cancer type that is that has a genetic component to it. Like, for example, lung cancer, we usually don't think about as having many genetic aspects of that. Okay. But yeah, I think anybody with a cancer diagnosis, it's worth asking their oncologist, is there any reason for me to see genetics? Or, the conversation is always worth having. Mm-hmm. Yeah. Okay. So, perfect. So let's talk about testing positive results. If someone goes for a genetic test,
and they do test positive, what typically is their next step? What do they do?
So it's helpful to meet with a genetics provider. So either a genetic counselor or a nurse or a physician who has expertise in that specific genetic condition is always helpful, because there's so many nuances to the different genetic mutations that you can have, and the guidelines for how we treat people with those mutations changes over time. So it's really helpful to meet with somebody who kind of knows this inside and out, which could be, like I said, genetic counselor, nurse, physician. If you are someone who's being actively treated for cancer, you might just go back to your oncologist first, because the first and the most important thing for that person might be a targeted therapy. So that might be the first thing that they do is go back to their oncologist, see if it changes their treatment plan at all, or opens up additional opportunities for clinical trials in the future or something like that. But if someone is not actively being treated for cancer, then I would recommend following up with an expert and then coming up with a plan in terms of how are we going to manage this increased cancer risk? Is it going to be more frequent mammography? Is it going to be, there's medications that you can take to lower your breast cancer risk? How are we going to manage it? And just figuring out what makes the most sense for you.
Okay. Yeah. And probably, I'm sure, connecting with an expert, having a plan in place is just something important, just to help with the anxiety that I'm sure is felt and the unease with that sort of positive test. So yeah, kind of having a plan in place. That's great. That's great. I remember when we connected before for our speaker series, a couple different terms came up. So germline testing and somatic or tumor testing. Can you talk about what the difference is in those two types, and even how they may relate to a breast cancer diagnosis and an ovarian cancer diagnosis?
Yeah, it's a great question. And it's really confusing because everybody just calls it all genetic testing, which it is, but it has very different implications depending on what it is. So germline genetic testing is when they look at the genetic information that you inherit from one of your parents that you can pass on to your children. So germline testing is kind of like the hereditary side of testing, or the side that if it's running in the family. And then somatic testing or tumor testing, you can use somatic or tumor. It's describing the same thing, basically. Okay. There's the reason that they do that type of testing is to see what mutations cause that cancer to develop, to see if there's a way to specifically target those mutations through personalized therapy. So it's that goal. The goal of that testing is treatment. The goal of hereditary or germline genetic testing is, did I inherit this from my parent? Am I passing this on to my children? So the goals are very different.
Okay.
There is some overlap in the results, though, which makes it even more confusing. So anything that you inherit will probably show up in your tumor, right? So if you have a BRCA mutation in your germline DNA, your inherited DNA, you will probably also find it in the tumor, because your tumor stems from your own cells. So anything that you were born with is probably identifiable in the tumor. But the converse is not true. So there's going to be lots of people who have mutations that are only in their tumor, that they did not inherit from mom or dad. They did not pass on to their children. They just happened over time and led to a cancer developing, but they were sporadic and not inherited. So just because it's in your tumor doesn't mean it's going to be in your inherited DNA, if that makes sense.
Yeah. So if a person had their tumor tested, and for sake of example, they found the BRCA mutation, and then they went back for the genetic testing, they could have a negative genetic test, is what is sort of that clarification. Okay. But the converse, it would always be a positive, and likely a positive.
Pretty much. Yeah.
Oh, and is there any difference in the breast cancer space and the ovarian cancer space? Is that different at all, or is the same in both worlds?
What I just said would be the same in both worlds, but there are slightly different tumor tests that can occur in the breast cancer space versus the ovarian cancer space. So something that I think came up in one of the questions with the breast cancer space is, what is Oncotype testing?
Yeah.
Or how does that tie into everything I just said.
Yeah.
So Oncotype testing is tumor testing. So it's done on your tumor.
Uh-huh.
But it's not exactly sequencing of the genes the way that everything else I've said has been. It's kind of a unique way of looking at the tumor, and they're calculating a score of how likely is this cancer to recur, how aggressive is this cancer, that kind of thing. And so they use this in newly diagnosed breast cancer patients to figure out should this patient get chemotherapy or not.
Right. Okay.
So it is a tumor test, but it's a little different even from like somatic or tumor sequencing. So it's even a little bit different than other tumor tests that exist.
Mm-hmm.
And it has like really no overlap with BRCA 1 or 2. So we get that question a lot, like, oh, I already had Oncotype. Do I need BRCA testing? And the answer is yes, because it's a very different test. Does that make sense?
Yes, absolutely. Okay, good. And I'm glad that you clarified the Oncotype because, right, I think that there is a lot of confusion.
Mm-hmm.
Going back to the germline testing, so that hereditary testing,
Mm-hmm.
is there, again, based on your recommendations on who should have that testing, does it differ at all for just general germline testing? So, for example, myself that has not had a cancer diagnosis, should I be talking to my physician about, should I have hereditary testing done for some kinds of genes if I think I may be at risk for something? Is that an appropriate conversation for any of us to have?
Yeah, I think especially if you have a family history of breast cancer, ovarian cancer, prostate, pancreatic, colon, especially at younger ages. So especially if family members are diagnosed under 50, I think it's definitely worth having the conversation. You know, you could always meet with the genetic counselor, go over all of the information and likelihood of your insurance covering it. And you don't have to have the test at the end of the day if you don't want to. But if you have a concern about your family history or you want to be really proactive, I think the conversation never hurts.
Okay. Good to know. And for those that just hopped on, I know we have several people watching. I just want to reiterate, we're here with Penn's Abramson Cancer Center genetic counselor, Danielle McKenna. She's answering all of these really important questions. Everyone is welcome to participate in the chat. We've seen some comments. Danielle, everyone is loving the information you're sharing, just finding this so incredibly helpful. So we're happy you're here with us. So feel free to add your own questions as we move along. Going back to the terminology and how confusing it can be, are there particular words or things that our community should know when they're speaking with their physician, or certain things that they should ask when entering into this conversation with their medical team? Is there any recommendations for that?
I think knowing the difference between germline and tumor is probably the most helpful, which we kind of already went over. So germline, inherited, somatic is tumor testing.
Okay.
And I think that can help clarify a lot of conversations with providers.
Yeah. Okay. And just kind of knowing the difference between the two. Okay.
Mm-hmm.
So after a person has their testing done, germline or somatic, what kinds of questions, should be asked, or is there a list sort of, that our community should ask in terms of, what was ordered? How do I know what it is? What do I do now? Like, is there sort of like a checklist that our community can take away so that they can make sure they're covering all of the important points?
Mm-hmm. So I would say in the germline context, so in the inherited context, after you get your results back, main questions are, what does this mean for me going forward? What does this mean for my family members going forward? And a genetic counselor, when they give you your results, should go over both of those things with you. Mm-hmm. If you're getting the results of a tumor test back or a somatic test back, then the question is, what does this mean for my treatment? How are you going to use this to personalize my therapy, kind of thing?
Okay. When would a family, or do you often, or might you as a genetic counselor bring family into the conversation and recommend testing for them? Would you, is that something like that you often do with your patients that you see or in your community, and kind of get everyone tested?
So anytime a mutation is identified in a patient, that we spend a lot of time talking about family members and which family members are also at risk for this mutation. How are we going to talk to them about it? What might change for them? what age should they be tested at? We spend a lot of time kind of going over all of those things once a mutation is identified.
Mm-hmm.
And then we also really try and help those family members get into genetics, because sometimes it can be hard to find a genetic provider that's nearby, or, you know, if they're not in the Penn system, for example, we help them get in the Penn system first.
Mm-hmm.
So we definitely spend a lot of time talking about that for people who have mutations. For people like yourself, who you said you don't have a cancer history, if you presented to genetics and you had a really strong family history of breast cancer, for example, and
Mm-hmm.
there were other people in your family with breast cancer who haven't been tested,
Mm-hmm.
we also, in that scenario, try and get the affected women tested first, because that's going to tell us the most about the risk for that family. So whenever we see a family of breast cancer or any type of cancer, we always try to start the genetic testing in someone who's had the cancer, because if we're going to find a genetic mutation, we're most likely to find it in that person.
Mm-hmm.
And if, hypothetically, if your mom was a BRCA carrier, but then you test negative for it, that is hugely informative, because we can say, you know, this BRCA mutation caused your mom's breast cancer to develop. You don't have it. Therefore, you go back to general population risk of breast cancer. Versus if you were just negative and we didn't know your mom's status, then we don't know exactly what to say for your breast cancer risk. So it's always helpful to have the affected family members go first whenever possible.
Oh, that's so interesting. Okay. Okay. I know you mentioned a little bit earlier, just, you know, how positive testing or testing in general can affect possible clinical trials and treatment. Are you, or any genetic counselor, are you connected with different clinical trials? Is that something a patient can look into themselves? Like, okay, I do have this mutation. Let me see what's out there. Is that something that's available?
So typically clinical trial recommendations would come directly from the oncologist,
Okay.
but patients can go on to clinicaltrials.gov and they can
Mhm.
enter information about their personal history to see if they can find anything
Okay.
to bring to their doctors. Genetic counselors might mention it if we find something and we know for sure that there's like a clinical trial at our center that they would qualify for, but usually it comes from the treating oncologist.
Okay. Okay. But at least they know they can go if they want to kind of do some research on their own. Okay. Because we know that sometimes, you know, if someone isn't savvy with some of the terminology, if they have their results in front of them, it can be quite confusing. Could anyone with their results schedule an appointment with someone like you, with a genetic counselor, and just say, can you talk to me in like a third grader, you know, like speak to me in a way that I can understand and bring the results to you? Is that something that's possible?
Yeah, absolutely. Absolutely. So that happens not infrequently, that we have patients who were tested on the outside. You know, they didn't necessarily get a lot of information before they had their genetic testing about what it could all mean, and then they get it back and they just feel very unclear about what it all means. So it's almost like coming in for a second opinion, but like a genetics opinion, and we're happy to see those types of patients.
Oh, that's so good. Because I think that maybe there, you know, people might not know, like, oh, can I go somewhere else? Can I, you know, am I able to bring my results elsewhere? So it's nice to know that, you know, that there are, you know, it's okay to seek a little bit of clarification from outside sources, or, you know, a professional on their own. That's really good to know. We had a question, and I know you mentioned this early on, but just about, should we go back for updated genetic testing every few years? So for those that hopped on a little bit late, would you mind sort of reiterating that timeline that you recommended?
Yeah. So before, if you had genetic testing before 2013, you should definitely come back, because there were some major changes that happened in 2013. If you've had genetic testing between now and 2013, it's a little harder for me to predict if you're eligible for updated testing, but you can always call the person who ordered your testing and see if they recommend anything updated, or you could call a genetics provider and they'll ask to see your report, and then they can let you know if you're eligible for anything. But it does change over time. So certainly if you've had negative genetic testing, you still have this really strong family history, you're kind of still left with not knowing what's causing the breast cancer in your family. Never hurts to check back in with genetics or your oncologist and say, do you think I should come back for more genetic testing?
Perfect. Yeah. Thank you. Yeah. So that 2013, good year to know for sure. And we had another question come in about, we talked a little bit about family member testing. At what age can daughters have genetic testing when mom has a breast cancer diagnosis with negative genetic results?
So if the person with breast cancer had negative genetic test results, then testing your daughters is probably not going to be very helpful because you're negative. So we know that you passed on normal copies of those genes to your daughters. Certainly they get half of their genetic information from their father. So if there's anything on their father's side that they want to explore, they can come in. But otherwise, what they typically say, and again, I'm not a physician, so I can't make recommendations, but what kind of the national guidelines are, is that daughters should start their breast cancer screening 10 years prior to when mom was diagnosed, or age 40, whichever comes first.
Okay.
So even if they don't need genetic testing, they might need to start their screening a little bit earlier, depending on when you were diagnosed with the breast cancer.
So good. Okay. Yeah, perfect. Thank you for clarifying that. That's wonderful. I know one of the other questions that came in about genetics had to do with PARP inhibitors. Can you speak a little bit to that in the genetics world?
Yeah, so PARP inhibitors is the class of drug that targets BRCA1 and 2 related cancers.
Okay.
And so in ovarian cancer, they're being used more and more frequently. And so that's why actually every newly diagnosed ovarian cancer patient gets sent for BRCA testing right away so that they know if they qualify for PARP inhibitors at some point. So in ovarian cancer, it's no longer really in clinical trials. It's part of clinical care. If your ovarian cancer is related to BRCA1 and 2, you will get a PARP inhibitor at some point.
Okay.
With breast cancer, we're not using it as early. So it's usually like if the first type of treatment and the second type of treatment doesn't work, then maybe they'll think about a PARP inhibitor. But again, every clinical trial is different. So this is worth bringing up with your providers. It changes all the time. But PARP inhibitors are the drugs that target BRCA mutations in tumors. And that should work whether you have an inherited BRCA mutation or a BRCA mutation in your tumor that is not inherited, but it's still there.
Right.
They still would consider a PARP inhibitor in that.
Okay. Oh, so good to know. Okay. And just for clarification, yes, around the comment about when the person was diagnosed at age 46, her daughters would start to get tested or start their screening at the age of 36.
Screening. Yeah. So start mammography or whatever breast screening they're going to do at 36, not genetic testing. It would be the actual screening for breast cancer at 36 would start then.
Perfect. Wonderful. Well, I think we covered a lot of the questions that came through, and you gave us some really good clarification on terms and, what to sort of do if a person has a positive result. So I appreciate that guidance. Absolutely. Just to wrap up our Ask the Experts that we have for today, Danielle, is there any final recommendations or suggestions that you have for our community regarding genetic testing or seeking out if it's appropriate?
I would just say, so I know there are some questions that came across earlier, specific genes that people can have mutations in other than BRCA1, BRCA2. So there are several other genes out there that we know about now that, can increase the risk of breast and ovarian cancer. And so if you have a mutation in any of those genes and you're not sure what it means or you want a second opinion, Genetic counselors are great people to speak with. This is all we do, all day, every day. So we can help you kind of decipher that information. And if you missed it earlier, you can actually Google find a genetic counselor and put in your zip code, and they'll tell you where the nearest ones are. And then, advocating for yourself, asking questions about genetic testing, asking your doctor, should I get genetic testing? That's all great advice for people as well. Just to show interest, because sometimes the family history may not be as obvious to your doctor as it is to you. So it's helpful to have those discussions with your doctors.
Yeah, that's wonderful. And for those of you in the Philadelphia area or with the Penn Health System, you can absolutely see Danielle later this year, perhaps, or someone in her team as genetic counseling, because she's absolutely wonderful. We had one final question that I think, just again for clarification, that those that may have hopped on, is Oncotype testing considered genetic testing of the tumor? Is it something completely different? So let's clarify onco testing again.
Yeah, so Oncotype testing is considered genetic testing of your tumor, but it's not looking at BRCA or anything inherited at all. There's no overlap with anything inherited. So Oncotype testing is strictly with the tumor, and it's just to figure out, should this patient consider chemotherapy or not to keep their cancer at bay. So it is a type of genetic testing, but it's very different from the inherited aspects of genetic testing.
Got it. Wonderful. Excellent. Well, Danielle, again, this is why we brought you back, because it's such good information. It's clear, it's concise in a world that is confusing and we're unsure about. So we appreciate taking all of our questions, sharing your recommendations, being a resource for the Unite for Her community. And we appreciate you very much. So thank you for being here. And thank you for everyone for submitting your questions.
Absolutely. Thanks for having me.
You're very welcome. Well, just to wrap up our Ask the Experts, again, this will live on the Unite for Her Facebook page. It will also be posted on our Her Library that you can see at uniteforher.org/Her Library. In addition, if you haven't checked out our speaker series that we did with Danielle and a panel about genetics and tumor testing, check that out in our Her Library as well, because it was full of wonderful information and a great accompaniment to today's episode. Again, I want to give special thanks. We couldn't bring this to you today without our presenting sponsor, Merck, and without our supporting sponsor, Exact Sciences. So, of course, we are so thankful for their support with all of our series to bring you more education and experts like Danielle. And then finally, just a nice reminder that we do our Ask the Experts every month. In April, we have 2 coming your way. So we are bringing back our friends at Triage Cancer to go over some more questions about disability. So if that's of interest to you, please tune in. That's April 21st at 1 p.m. Eastern Time. In addition, we are bringing on an expert about lymphedema, and that will be April 28th. At 3 p.m. Eastern Time. So a little bit of a time change there, but we'll be promoting it all month long. As always, thank you so much for being with us today. Thank you for all your questions, and we will see you all again very soon. Take care.